Hello, everybody, and welcome. Thank you for attending our 8th CfSD National Clinical Pathways webinar. My name is Stuart Sutton. I'm a GP and clinical lead for primary care, secondary care interface. These webinars are designed to showcase pathways that have been developed by CfSD in collaboration with clinical communities and to provide a forum for education, informal discussion and question and answers. And today's webinar relates to the severe asthma pathway. So for today, the webinar will be recorded and it'll be available on the CfSD website subsequently. There is the opportunity for questions and answers. We'd really encourage questions. It'd be fantastic to get some interaction towards the end of the session. If you can make sure you use the Q&A box or icon, which is just next to the chat function, that allows us to collate all of the questions, provide some answers in the box, and then also maybe do some question and answers at the end as well. And then obviously at the end when we're doing the Q&A, feel free to raise your hand if you want to bring anything in otherwise. So without further ado, I shall hand over to Professor Tom Fardon, who is the chair of the SDG respiratory team. Thank you.
Yeah, thanks very much. My name is Tom Fardon. I'm a respiratory consultant in NHS Tayside. I have a specialist interest in severe asthma, and I am the clinical lead for the Respiratory SDG, and I chaired the severe asthma group along with Arlene and Corrine, who are with me today, but also a truly multidisciplinary team, which with representation from most of the boards across Scotland, and we had consultation with every board in Scotland. So this, I think, represents the consensus view across the whole of the country. We are the first of the UK nations to provide a severe asthma pathway. We're going to talk briefly about the BTS sign NICE 2024 asthma guideline, and it notably doesn't have any mention at all of severe asthma. And the British Thoracic Society, in collaboration with NICE, are just embarking on the process to come up with a severe asthma pathway. So we're a good couple of years ahead, and I think this is a piece of work that I've personally been involved with for 3 or 4 years, and very proud of what's come out of it. And I should acknowledge all the hard work that's been done by the people who are along on the journey with me. I think it's important just to recognise that asthma is a disease that's not going away. Asthma diagnostic rates have come down to some degree over the last 20 or 30 years, but there's a slight increase in the diagnosis in the last 5 or 10 years. And perhaps more concerningly, the rate of death from asthma has not gone away. And you'll see, it's very small on my screen, but you'll see that the rate of death is starting to split between male and female, to be a significant difference between with an increased risk of death for females and an ongoing downward trend for men. So there is an inequality already that we can see in severe asthma. And there's an even bigger inequality in terms of deprivation, affluence and poverty. And on the left side, you see the graph of diagnosis of asthma separated out into socio-demographic indices. And the diagnosis of asthma is found in areas of affluence, but those people in affluent areas are very unlikely to die from their asthma. The people who are more likely to die are those who live in poverty in areas of deprivation. The people who are increased risk of dying of asthma are those people that it's very hard to get in touch with. They are notoriously difficult to entice into follow-up. They tend to default from primary care and secondary care follow-up. They tend to use emergency services as their primary source of help and care, and we'll talk about that a bit later on. But asthma deaths have not gone away. We can start to identify subgroups and populations that are most at risk, and that's why it's still so important today that we talk about severe asthma. We can predict quite nicely those people who are increased risk of death, and this is from the previous asthma guidelines. These are from 7 years ago, and the adverse behavioural and psychological features recognised by one or more of. I'll not read through them, but many of these are associated with deprivation and poverty, and I'm sure this is very recognisable to most of you, that the patients with what we term difficult asthma, that is asthma that's difficult to control despite optimal inhaled and therapy and now injectable therapies with biologics, these people still have an increased risk of poor outcome, poor response to biologics, poor response to inhaled therapy, and ultimately death. A little over 10 years ago, the Royal College of Physicians in London commissioned a report called Why Asthma Still Kills, the National Review of Asthma Deaths, and they reviewed every death attributable to asthma in 2013 with a panel of experts to go through why it is that these people died. And again, I'll not go through everything, but you can see on the screen that that half of the people, almost, who died of asthma did not seek medical assistance before they died. Half of them were not under specialist review. About half of them had been to a hospital and been admitted in recent history, so were already identified as being at high risk. 1 in 10 died within a month of that discharge from hospital. And over half had attended twice or more to ED departments. So the signal was already there. We could already see what predicts a poor outcome, and this is from over 10 years ago. Very few people who were investigated had a personalised asthma action plan, despite good evidence that they saved lives since the 80s. Half had not been for a formal asthma review. We're not good at documenting triggers. We're not good at documenting what exacerbates patients' asthma. It was said in the review that 60% had non-severe asthma. In subsequent analyses of this, what actually that means is that 61% of patients were classified as having non-severe asthma. They actually did have severe asthma, but it just wasn't noted, and they were taking insufficient treatment, undertreated, and lack of recognition of eosinophilic Th2 high asthma, which was the cause of their death. Martin Partridge wrote in the introduction that the best result from this report would be that the recommendations are implemented and a further service review of asthma deaths will not be required because few people die from the disease. I published, along with Dom Shaw and Katie Pink and Jay McDonnell in Thorax last week, an editorial saying why we think we need to repeat this process, and we will be doing an NRAD 2, hopefully by the end of this year or into next year, because asthma deaths have not gone away. And the 3 main groups of people who we can identify straightforwardly of being at risk of an asthma death are those people who either overuse SABA, and by that it's short-acting beta agonist, the salbutamol, terbutaline, Ventolin. Those who underuse inhaled corticosteroids. This picture is a Becketide inhaler, which shows how old I am because they've not been available for many years. But I think many of us recognize the brown inhaler, blue inhaler sort of trope of how to manage asthma, and OCS overuse. So that's oral corticosteroids in the form in the UK of prednisolone. So I'm going to hand over to Arlene, who's my colleague in NHS Tayside, a specialist respiratory pharmacist with an interest in severe asthma, who's going to talk to us about why SABA overuse, ICS underuse, and OCS overuse are so dangerous in this cohort of patients. Thanks very much, Arlene.
You're on mute, Arlene.
Sorry, you hear me now? Yeah, okay, sorry. My name's Arlene. I'm one of the pharmacists in NHS Tayside. Worked in respiratory for quite a long time. And I am going to talk to you today about SABAs, ICSs, OCSs, and the new BTS sign NICE guideline. So there's a couple of graphs here, and this shows you, these are both studies from New Zealand, which show you that, hopefully quite convincingly, that the more SABAs or short-acting beta agonists you use, the higher your risk of death, and that can be seen on the top graph. There's a clear trend there in the increase in number of SABA devices against the risk of death. And conversely, in the bottom graph, what you can see there is that the more people use their inhaled corticosteroid, the less chance there is of them dying, which I think is relatively convincing evidence that these are both things that we should target. Another paper which used albuterol, which is the American version of our salbutamol, again way back in 1992. At this point, there's a clear signal here that the more SABA patients are using, the higher the risk of death. So if we look at some of those numbers, we can see the risk of fatal asthma outcomes sharply increases once you're using quite a small number of SABA devices, actually, so even between 1 and 12, which is a broad range, but your risk is 4.7 times higher. But if you look at those that are using more than 25 in a year, there's 113 times risk of death in that cohort. And similarly, the group on the left-hand side, those are patients who have near fatal events and also deaths. But again, we see a rise in those numbers. So despite quite convincing evidence, these are graphs that were taken from the National Therapeutic Indicators. I think these are a couple of years old, but they're not changed massively in that time frame. But what we can see is that in Scotland, there's a significant amount of patients, so average around about 30% of our asthma patients who are still using more than 6 SABA inhalers a year. And you can look at that per individual board, but as I say, the average is about 30, and the NHS Scotland average sits in the middle of the pack there. On the right-hand side, what we can also see is that around about 20% of our patients in Scotland are still managing their asthma with a SABA-only device without the inhaled corticosteroid, which is obviously a concern. I'm going to skip that slide. This paper from back in 2017, this gives you a summary of some of the risks that are associated with even short courses of oral steroids. So we know if patients are having exacerbations, they do get steroids, and there's perhaps a perception that a short course of steroids won't cause much harm. But what we can see from this is that even one short course of steroids, and even at very much lower doses than we use in practice in asthma, there's a significant increase in risk of sepsis, VTE, and fracture. So if we look at the doses of 40, well, even 20 to 39, which is slightly below the dose that we would use, what you'll see is about a 7 times increase risk in sepsis within the first 30 days of that exacerbation. In the same group, we've got almost 3 times risk of VTE and double the chance of a fracture. So not insignificant numbers, and that risk persists but does reduce slightly if we look into the corresponding 90 days. And I suppose it's just to highlight that, you know, it doesn't take much to cause these risks. We know patients' asthma is a chronic disease. Obviously, patients who are not well controlled will have repeated courses of steroids, and with that repeated exposure, the risk from the cumulative dose does continue. So, you know, a 5-day course at 40 milligrams, which is what we would use for asthma patients, will give you 200 milligrams straight off. So even somebody using one course once a year for 5 years is giving you a 2000 milligram exposure, which, as I say, quickly mounts up. This slide gives you, I'm not going to go through it all in detail, but it highlights all the sort of longer term risks of repeated oral steroid exposure. This is a poster that it's just launched, and it was developed by the Scottish Respiratory Pharmacy Interest Group, and it's some guidance around oral corticosteroid prescribing in asthma and COPD. And one of the main aims and objectives of it is around to dispel some of the myths that are associated with oral corticosteroid prescribing in respiratory disease, and particularly airways disease. So I think what we've tried to do there is highlight the risks that are, as we've just seen, that are prevail when with quite a small number of doses of steroids, but also the consequences of that, and try and encourage, good oral corticosteroid stewardship going forward. But the other sort of key message in there is that, if a patient's requiring 3 courses of steroids or after their second course of oral corticosteroids with asthma, then that's kind of a red flag, and it should prompt referral to secondary care for looking at other treatments. And that brings us on to the BTS NICE sign guideline, which was published, feels like not long ago, but it was back in 2024. It's about a year and a half ago now. And this was a significant change in the management of asthma recommendations. And a lot of it was set out to address some of the issues that we've just described. So what the sort of tagline is that we're looking for a SABA-free future. It introduces the terms AIR and MART, which hopefully you've come across. There's an emphasis on phenotyping, and particularly the Th2 predominant disease, and as I said, early referral to specialist asthma centres. So just around the terms AIR and MART, in case it's not familiar to you. So AIR is the anti-inflammatory reliever therapy, and that essentially means taking the SABA device that a patient would traditionally take and the inhaled corticosteroid device, and combine them into a single device that the patient uses only as and when required. So they're using both the SABA and the ICS as and when they're required, and that's for mild disease. I should highlight that it's only applicable to dry powder devices, and it's only appropriate for formoterol containing LABAs. And then MART is a similar principle, where the SABA device and the inhaled corticosteroid plus or minus the LABA is combined into a single device. And in that situation, the patient uses their combination device morning and night, and also as required. And from that big long guideline, this is what we've introduced in Tayside as our local treatment protocol. So we have went with Symbicort as our dry powder device, and we use Proxor as our MDI MART device. So just to spend a couple of minutes on this, as with any inhaler regime, we strongly advocate that the device choice is driven by the patient and the device type that they can and will use. So whether that's a dry powder device or a metered dose inhaler, and that's the sort of starting point around decisions for which device to choose. And then, so on either side, there's one for DPI, one for MDI. But if we look at the DPI one, what we have here is Symbicort, and on the far left, we have it as AIR. So that, again, once they use one puff just as and when required, and that can escalate into sort of low dose MART, which is the 1 puff twice a day and 1 puff as required, or increase up to moderate dose MART, which is Symbicort, 2 puffs twice a day and 1 puff as required. And by selecting that one device across all spectrums, it allows the flexibility for the patients to move up and down their treatment regime as and when they need to, and we know they probably do that anyway. But what it does is it ensures that the patients are getting the inhaled corticosteroid at the point that they have symptoms, in addition to the SABA, which we know so many patients rely on and are quite happy to use as their mainstay of treatment. But we know the risks of that, and we know why that's not a good thing. In the MDI side of the algorithm, obviously we don't have an MDI AIR option at the moment, so we do have the traditional single devices of ICS and salbutamol. And even at very mild disease, it would always the regime would always contain inhaled corticosteroid, so no SABA only. But then we do have, well, we use Proxer in Tayside, but there's other MDI options which are available for MART. In terms of our local implementation of the new guideline, for all the reasons we've described, our sort of priority adoption programme is looking at anybody that's newly diagnosed with asthma now does not get offered a SABA, that they're offered a AIR or MART regime, and no blue inhaler to just in case. Then probably our next highest risk patient that we think we want to target, or we're targeting, are those that are prescribed the SABA onlys for the reasons we've already said. So we obviously know they're undertreated, that it's significant clinical risk, and if we can give them an AIR or a MART, we know that at least when they're taking the reliever inhaler, they're still getting an inhaled corticosteroid dose. Those who are poorly controlled, that's maybe obvious that we can optimise our treatment regimes. Patients who are overusing SABAs, again, I feel like I've kind of been through all this, but those that are using lots and lots of SABAs are possibly not using their ICS. They're not well controlled, but AIR and MART is an ideal regime to look for those patients. And similarly, the ICS under users, as Tom alluded to, we know they're at risk, and AIR and MART does ensure that they get their inhaled corticosteroid dose when they're using their reliever. And then just lastly, as I said, the NICE BTS sign guideline, one of the main reasons, or one of the main sort of messages in there, is to ensure early referral to secondary care. And one of the reasons, not the only reason, but one of the reasons for that is that we do have biologic treatments available now to offer these patients, and these can be quite significant and potentially life-changing for quite a lot of asthma patients, and we hear this sort of day in, day out in our daily practice. So we know you can reduce exacerbations quite significantly. It reduces hospital admissions, and we know it can have steroid-sparing effects. We can wean people off it, any oral maintenance steroids, or actually reduce the number of exacerbations and reduce their steroid exposure that they are suffering from. I'm going to hand back to Tom.
Thanks very much. So that's great. I think that it's so under-recognised across primary and secondary care, the impact that oral steroids have on patients. I see a very narrow view of people who get referred to me, but I see a lot of people who are being given a lot of steroid and have got secondary antibody deficiency, have got a significant degree of immunosuppression, have become colonized with gram-negative bacteria, have become dependent on steroids, and have all those side effects. We know that the people who do worst from the UK Severe Asthma Registry are those people who have obesity, those people who have neuropsychological difficulties, and they're caused by and worsened by steroids, and we're giving people steroids that make their comorbidities worse, that then mean they have less response and have worse outcomes. So, and on top of that, I'm always surprised by that data, that your risk of sepsis goes up by such a significant amount after a really short course of steroids. So what did we do about this? Just after we'd entered the post-COVID world and we were able to start doing project work remotely on Teams, and that really was a revolution for us, because we were able to pull together colleagues across the whole of Scotland to start working together, rather than having to plan a meeting in Edinburgh or Glasgow or somewhere which no one could ever meet. So we started the Severe Asthma Pathway for Scotland, and this was published on the CfSD website last month, perhaps the month before, and it's a culmination of about 4 years of work to try to work out how can we distill together everything we know about severe asthma and get the basics right, make sure we're doing the basic building blocks of asthma care properly, but then we're identifying those people who should be fast-tracked towards biologics because they're so life-changing that we really need to open access to those people. And as I said at the beginning, the people who often need it the most are the people who are least likely to present to us. Those people who don't turn up to their follow-up, don't engage with primary care services, those people who are at high risk of sudden death and poor outcome. So how do we do that? So the first part that's important, and Arlene has already mentioned that, is that the primary care management, the initial management of asthma is Sign 245. That's the BTS Sign NICE guidance published in November of 2024, the first time that Sign and NICE have agreed on how to manage asthma. And if you've not seen that, and I do encourage you to go and have a look at that. It's such a simplified way of treating asthma, making the diagnosis and moving forwards, but it does prioritize referral onto us for severe asthma and consideration of biologics, and that's what we're going to talk about, how we implement that. So we have this 5-step approach of identifying patients with severe asthma that we should be seeing and seeing them quickly. When we see them in clinic, we need to make sure that we're talking about the right diagnosis, confirm the diagnosis is correct, because many asthma mimics. There are asthma plus syndromes, so we need to make sure that asthma is the main issue here. Determine what the driver of airflow inflammation is, so that's phenotyping, and I think we spend a lot of our time in asthma MDTs across the country phenotyping our patients, coming up with what is the, trying to move from the biochemical or biological markers into phenotypes, which is how do we describe our patients, and then into endotypes, which is can we predict which of our biologics is going to work for our patients. The approach to selection of that biologic therapy is then very much based on that. Can we move on from markers to phenotypes to endotypes? And then how do we judge the effectiveness of the treatment? How do we organize management of follow-up? So this is just a reproduction of what the guideline is. I know that it's quite busy and I'm not going to go through the whole slide, but what I want to just point out to you is that we have on the left side criteria to identify patients at risk of severe asthma. So that's people who are overusing SABA, and we've picked 6 SABA prescriptions in 12 months, or are exacerbating frequently. So that's 2 or more exacerbations of OCS should trigger a review, or they're very symptomatic. So an ACQ of more than 1.5. Direct referral to a specialist asthma service is in for anyone who's had 3 or more courses of steroids in a year or is on maintenance oral steroids. And that's really important because although there really shouldn't be people out there on maintenance oral steroids, we know that there's a significant number of people who are taking maintenance steroids for their asthma and are at incredibly high risk of poor outcome and complications. So we really need to prioritize those people. We still have in this guideline guidance on optimizing therapy, talking about adherence, talking about inhaler technique, modifiable risk factors, and a whole raft of information on what tests are useful for us to know, including eosinophils, IgE, and other tests, so that you can then make a referral to secondary care on an urgent, non-urgent basis so we can see patients. But ultimately, what we're looking for is people who exacerbate a lot, people who are getting lots of steroids, and people who've got an elevated eosinophil count and an elevated pheno. And those people are the ones we want to see as quickly as we can. When we see these people, they're referred up, and we have a national process for enhanced vetting, or ACRT, where we can move people, fast track them into severe asthma clinics. We do the baseline test that you'd expect us to do, pulmonary function testing, reversibility, in some cases, not all, pheno, baseline blood tests. We have some recommended tests that can be done additionally, depending on availability in different areas. We do CT scans on most of our patients, not all, and we look for immunodeficiency and alternative diagnosis. We do pharmacogenetics in Tayside. It's available across the country if anybody wants to do it. We do ask, though, that eosinophils are tested in the community because it's such a helpful triage tool. Up front, we know if patients need to be fast-tracked if they've got eosinophil predominant disease, because we know the eosinophil drives the disease. It's not just a marker of activity, it's the effector cell in asthma. We have a pathway of assessing adherence. We address modifiable risk factors, and there's obviously many of those in asthma. We have asthma plus syndrome, so there's people who have asthma plus something else, and commonly in asthma, that's chronic rhinosinusitis with nasal polyposis. It's a terrible acronym, CRSWNP. Gastroesophageal reflux, anxiety and depression, and other psychological and psychiatric diagnoses. Breathing pattern disorder is increasingly common in this group of patients and increasingly treatable now, as we're developing within CfSD, working with the NHS Academy. We're now developing a breathing pattern disorder framework and strategy, and we'll be talking about that hopefully in 2027. ILO, inducible laryngeal obstruction, is very common, mimic of asthma, and again, something we're working with our AHP colleagues around. We do aim to optimize treatment by making sure patients are on air and MART and on sensible treatment, and we have a number of colleagues across the hospital who are able to help us in other specialties when needed. We collect a minimal data set. We're doing that across all centres across Scotland, so we can compare our performance against other centres, and we hope to, with the guidance of Rory Chan, to be able to publish on that in the next couple of years. This is really to remind me to tell you that this is quite complicated, and this is certainly not something that I want you to go away and think about phenotypes. So this is what we're thinking about when we're trying to come up with plans. We're trying to take all of the biochemical and biological markers that we measure in asthma and then convert them into phenotypes and endotypes. And we broadly think about Th2 high asthma, which are those patients who've got lots of active inflammation we can treat with biologics, and the Th2 low asthma, who unfortunately don't have as many options. And that's an area for research interest that we're trying to develop. How do you manage difficult asthma? That's the sort of group of difficult patients. But the Th2 high group are the patients we're really looking for, and they're the people with a high pheno and high eosinophils. They typically have allergic disease, nasal disease, often lots of sputum, and we've got options for them in the form of all our biologics now. It's complicated. It's an evolving area. We know that the interface of the epithelium to the smooth muscle is now not a straightforward pathway, but it involves cytokines in all directions, many cells, many interactions. But what we do know is that the eosinophil is often central to this, and degranulation of eosinophils, releasing cytotoxic chemicals and eosinophilic extracellular traps is what causes asthma in this group of people. So when eosinophil counts are high, we know that that's driving the disease. We can measure IgE as a proxy for allergy, and we can measure pheno as a proxy for IL-4 and IL-13 activity, which you'll see very small on this graph, is integral in the proliferation of eosinophils and migration of eosinophils into tissues. So we now have ways to measure some of these things, and we have ways of then targeting with specific biologics. Because it's complicated and because this is a challenging area, we have guidance in the severe asthma document, which helps MDTs make these decisions. So every MDT across the health boards for Scotland is making these decisions. We had our MDT today, and so Arlene and I were part of the team that made these decisions for our 7 or 8 patients we saw today. Which biologic do we think is going to be the most effective for patients in our care? We took a long time to talk about which order we might give these biologics, and ultimately what we came up with is that all of the biologics, be them omalizumab, mepolizumab, benralizumab, dupilumab, and tezepelumab, could all be given first line for asthma. This deviates slightly from the SMC guidance for dupilumab, because when it was licensed as second line. But we know now from 5 years plus of experience that we can select the patients who will do well on dupilumab, and so it's only reasonable that we offer them that as first line treatment rather than expect them to fail on something to then only get it second line. So that is a deviation from SMC. That's been through SMC. They're happy with that because they defer to our expert opinion, and that's why. But there is that little asterisk there just to remind us that it does deviate from SMC guidance. There's a whole load of different considerations. I just bring your attention to the one at the top of additional considerations, which is realistic medicine and value-based health and care. And that obviously sits above everything that we do, particularly in CfSD, to think about realistic medicine and patient preference, geographical location, ability to take the injections. All these things are really quite at the forefront of the decisions that we make. Corrine will probably touch on that. I mean, as she's in the Highlands, geographical spread is something that's really important to her and her practice. But even today, Arlene and I were speaking about a patient who we had some concerns wouldn't be able to manipulate the injections, and that did influence our choice of biologics. So this is not just numbers. It's and it's no simple algorithm. There's a lot of thought put into this. And then follow-up. So biologics are initiated. Most centres across Scotland have moved to home care. So there's direct delivery of these medications to the patients. So they don't have to come to hospital. They don't have to be or speaking to us to order their drugs. We review patients at 3 to 6 months. We do some objective and subjective assessment of their response to the treatment, using validated questionnaires and assess response as objectively as we can. And we then separate people into good response, partial response, and poor response. We have multiple choices, so the patients who have a poor response can move on to another biologic, and we do see people respond to the second or third line treatment in some occasions. Some people just have an amazing good response. They'll tell you 6 hours after they took the benralizumab, they felt like a completely new person, and they come in and hug me in clinic, and it's really quite an amazing thing to do, because the people who do respond, you know, it completely changes their life, and people don't hug easily in Dundee, let me say that. So for them to come into my clinic and hug me is quite a big deal, but it happens regularly. When we do get people stabilized on these drugs, it's not over. We aggressively wean maintenance oral steroids. We're weaning inhaled therapies. We're weaning oral therapies that were never very effective in the first place, and people are very keen to stop them. And then we're making sure that there's a follow-up process so that we can ensure people are stable on these drugs and have an ongoing long-term condition plan in partnership with our primary care colleagues. We now in Tayside have nearly 500 people who are on biologics, and I think over 350 of them are now on a virtual review process because they're stable. So this 5-step approach of identifying patients in primary care, ensuring we're treating the right people by confirming diagnosis, looking for the driver of inflammation by doing some biologic testing, moving biologic testing to phenotyping to endotyping, pick the biologic through an MDT discussion, and then assess response and follow-up. And that's what we've now been doing for a while. So it is a truly multidisciplinary approach. You've heard a lot from me, the doctor. You've heard from Arlene, who's a pharmacist, and now we're going to hear from Corrine, who's a specialist nurse and runs the show up in NHS Highland. She's going to talk about implementation of this plan and her experience up in Highland. Corrine, are you there?
Yep, I'm here now. Thanks very much, Tom. Welcome everybody. End of day this Monday afternoon. I've been tasked with just giving you a little whistle-stop tour of how we actually implemented the asthma guidelines in NHS Highland. And I've really had the privilege, as Tom said, over the last 4 years with working with a very esteemed group of colleagues across the country in developing these new asthma guidelines, and hopefully in NHS Highland, because we're a wee bit different from a lot of health boards in Scotland, we've had to adapt and modify what we do a wee bit. And really what my priority was how do we actually get Hamish, who lives in Durness, the same equity of care and access to our severe asthma service as somebody who's living in our Murray Firth area. You'll be aware, NHS Highland covers, somewhere the landmass size of Belgium. So that causes its own problems, and how do we actually get these patients to see the right people in a timely manner? So really, we had piloted, you know, the Severe Asthma Pathway for Scotland was just published last month. There was 2 previous versions that we'd done through our precision group that we had piloted in NHS Highland. So we always had a severe asthma pathway updated to our TAM guidelines. And obviously in February of this year, we updated the new CfSD publication. But it really offers us a really gold standard structured process of identifying these patients and how we actually get them from secondary care referred us, primary care referred to us in secondary care. And really it's provided us with this evidence-based framework. It's given me the support as a clinician that we're doing the right things and that it is absolutely evidence-based. And you know, we've actually managed to increase our biopenetration of our biologic therapies in a very remote and rural locality in NHS Highland, and we've got patients on biologics across the whole health board. How has it actually affected our service impact? I mean, when we started first, you'll be aware as well, you know, we don't have the huge teams of in our severe asthma pathway. I wear lots of hats. It's not just severe asthma that I do, although it is the thing that puts fire in my belly. But there was actually the inception of NHS Highland Severe Asthma MDT, and with my consultant colleague, Lorna Murray, to begin with, there was only 2 of us sitting there and thinking, you know, is this the right thing? That is now, you know, expanded. We're now holding 4 weekly MDTs, and we're on average initiating between 6 and 9 new patients per month onto a biologic treatment. We've also reinvented our MDT Performant. We've now got a digitised one. But I think what is the most glaring, you know, impact from us using a structured severe asthma pathway is that we've managed to actually get our own respiratory consultants and our registrars to improve their vetting process. There's still work to do, and my colleagues who are online will agree with me with that, but certainly we're getting better referrals. Over the last couple of shifts I've been e-vetting. I've had the confidence to put them back to primary care to say, please look at the guidelines, we're needing X, Y, and Z done, then re-refer into us, and we're even getting pheno done in primary care in NHS Highland, which is a bit of a coup. Just because we've increased our biopenetration, our respiratory nurse clinics have gone through the roof. We're doing about 200 clinics a year with no additional resource, just you know, goodwill with me and my colleague, but it's a great clinic. Anybody that does severe asthma, when you're using biologics, it's a great clinic to do because it's so rewarding, you know, because you see these, you know, patients who, you know, have got no quality of life when they come into your clinic to begin with, and then as Tom says, you know, they're coming in and they're cuddling you and they're, you know, thank you for the pixie dust, it's, you know, liquid gold. So yeah, it's a really rewarding clinic to do. I'm hoping to adopt like what Tom and Arlene are doing in Tayside. For these patients that are the super responders that are very stable, we need to get them on a patient initiated review, which is very structured. But the guideline being there has allowed us to adopt the Penenti steroid weaning protocol. And again, that is, you know, given me the confidence as a, you know, a clinician and a prescriber to what to do with their steroid weaning, you know, as they get the benefit of their biologics. We sort of took opportunity when it knocks, when the BTS sign guidelines came out, in that we, you know, completely updated our asthma guidelines on our TAM site, and we actually integrated the severe asthma pathway onto those. Myself and consultant colleagues, we delivered education across the acute site, and also ED and out of hours practitioners and GPs. We held an industry supported event which had over 60 GPs attend, which again was a great coup. And locally there's there's public health and GP cluster groups looking at, like what Arlene was saying, these high SABA users, you know, the ones that are not picking up their ICS. And, you know, we've got Google Analytics data that looks at how often these new guidelines are being updated. And we're also running a emergency department asthma pilot box at the minute. This is just, I'm going to skip over this. This is just how we laid out our guidelines, a wee bit different from Tayside. But again, in step 5, we've now got an active link that links directly onto the Severe Asthma Pathway for Scotland. So it should be seamless. We integrated, obviously, all our own, the patient information, the asthma action plans, that anybody that accesses the guidelines has access to all these different patient resources. And obviously we have in NHS Highland, we've got our own respiratory resource hub. So we've got the QR code on the guidelines so that patients can access that as well. Just very quickly, the asthma box pilot, I unremorsefully even stole this from Tom Brown in Portsmouth and Gail McEwen in Northern Ireland. To go back to what Tom was saying about the NRAD data, we know that 21% of patients who had died had attended A&E within that 12-month period, and half of those that attended actually attended on multiple occasions. Now, I've been very much aware since I've been in post that ED has been a bit of a, you know, a black hole, and I know that I wasn't getting referred patients from ED. We know, particularly when, you know, Shelley, my colleague, and I are looking at, you know, hospital admissions, prescription recall, adherence, you know, when we're working people up from biologics, it was astounding how many of these patients had actually presented to ED. And again, something had to be done, because we know that, again, from NRAD, you know, 48% of those that died, when they looked at it, you know, why these patients were dying, there was 48% that actually weren't following guideline-led care. And I think that is the impetus of ED, is if we can get these patients that are coming into ED to get them discharged with the new guideline-led care, that should hopefully help reduce our asthma mortality. It's very simple, you know, we just include, you know, peak flow diaries that we're optimistic that somebody might, you know, actually fill in by the time they come back and see me at a clinic. There's documented asthma action plans, there's smoking cessation advice, again, a QR link to our respiratory resource hub, and placebo devices for the AirMart inhalers. We've just gone solely with Symbicort in NHS Highland. Tom and I were presenting a couple of weeks ago now, south of the wall, and if I came back from that meeting with anything, I was very envious of the data that NHS England and Wales are able to capture, and that they do capture. We're not very good at it, although we are so far ahead in a lot of things with the severe asthma service. You know, we're starting people on biologics within 2 to 4 weeks after decision at MDT in Scotland. You know, they're waiting 63 weeks in some places in England and Wales. So, you know, we have to take heart from that we are doing things, you know, really well. And as Tom intimated at, you know, hopefully the SARN data that is going to be publishing, hopefully in the next wee while, that should capture some of this data. I mentioned the Google Analytics. It's very limited. It only is actually giving us the numbers of who in NHS Highland are actually accessing the guidelines. It isn't just me and my colleagues every day, it is lots of other people. And I'm currently doing a formal audit of the asthma box in ED in Raigmore here, just looking at, are these patients being discharged with guideline-led care? Are they being given an asthma action plan? Are they having their inhaler technique checked? Are they being given the correct dose of prednisolone? Are they been asked to contact their GP, and are they actually being referred to specialist airways team for review? So there's lots of really exciting things happening at the minute, but there's still lots of work to do. But as I say, we've all got some fire in our belly and excited about this, but it's really about saying we've got these wonderful guidelines now. Let's all use them, and let's hopefully our patients will benefit from them. Thank you.
That was a fantastic presentation. I think we can all agree. Multidisciplinary and loads of learning for me. I can certainly reflect on. I think your slides with the histopathology gave me flashbacks to medical school, Tom, so I'm not going to thank you for that one. But certainly the Sabbath-free future is a really good framing. I think it's simple, isn't it? And it, looking at the data that Arlene shared, there's clearly a high percentage or too many patients who are kind of still on that treatment, and most of those will be managed in primary care. So yeah, lots of really useful learning, and we've got some questions. So before I hog the floor with questions that I could ask, I'll move over to the ones we've got in the chat there. So we've got from Dot Partington, are there any MDIs pending for air therapy? Forgive me, there's a small p. I should know what that is, but I have no idea the acronym for the small p. Tom Aldo.
Pressurized.
Thank you.
So, I mean, Arlene will trump me here because she knows more than I do about this. But for air, the 3 licensed treatments are Symbicort, Duo-Res Respimat, Duo-Res Spiramax, sorry, and WalkAir. The WalkAir inhaler, I think, has been withdrawn because of a manufacturing problem with the inhaler. We certainly can't get hold of it anymore. And then the choice between the two, that although the Duo-Res Spiramax looks like an MDI, it's not. It's a dry powder. So it has. I think it's a not unreasonable device. But there are other challenges with making formoterol stable enough that it doesn't need to go in the fridge and it lasts long enough and doesn't run out of date, because that's a problem with air. Because if you're only you need 2 inhalers per year, then it needs to last 6 months. And so things like Foster, for example, which has formoterol in it, has a limited shelf life of a month or so once it's out of the fridge. So I think there will be Me Too licenses. I think that other companies will demonstrate that there is equivalence, or at least non-inferiority against Symbicort, but those trials will take a bit of time, and it will be. So for the moment, we are on with DPIs. I just want to reassure people that DPIs are good devices, and across Scandinavia, for example, 80% of inhalers prescribed in Scandinavia are DPIs, and they have as good, if not better, outcomes than we do in the UK, where it's the other way around. I try quite hard to give people to encourage people to take DPIs. I think they're better devices. They're better for the planet. They're easy to use. It's a simpler technique. Breathe in as hard and as fast as you can, without any coordination. So that's that.
Thanks, Tom. Next one, I've got Joyce McDonald. Working out of hours, see patients from time to time relying on salbutamol from us or ED. Should we be considering stopping MART or air inhalers for those who don't engage their GP? I'm going to see nods. I think that's an easy one, so I think that's a yes. So that's a great action to take away from today's meeting, so thank you. We've got a question around from Rachel Stevens. Where can we access the oral corticosteroid poster? So we can maybe, if we can ask for a link to that poster or data. We'll share that. Yep, that would be great. Thank you.
I think it is coming out through the MCNs, but it's only launched last week, so. Fantastic. So it's literally hot off the virtual press nowadays. Okay, thank you very much. The PDF press. And we've got, this is a question that I was going to ask, so I'm glad Catherine Fraser's asked the same question. So we'll be referring far more patients from primary care. Is there additional funding and secondary care support? These current wait times are already significant. I suppose I guess that's one of the things that might happen as a result of this. If we're doing well, we should be identifying more people and referring them. And I look at the referral criteria and think maybe that's the case. I don't know what you think, Tom. Maybe not necessarily about the funding, but I guess is it more of an existential question of that would be a good thing if you get more referrals, I assume.
Yeah, we want to see these people. The evidence is so strong for these drugs, and we have been doing this since 2018. I think MIPO was maybe 2018, that sort of. So we've got a lot of experience with these drugs, and we see that the life-changing effects of them. So yeah, we want to see people. We need to be able to transfer people onto a patient-initiated review, virtual review process, and we need to hand back to primary care. We can't see these people forever, but biologics for asthma their safety profile is excellent. They are not immunosuppressive in the same sense that many other biologics are. Patients are not at increased risk of opportunistic infections. They don't need routine blood tests. They don't need to monitor their white cell count, etc. Once stable on these drugs, they are stable and they will do well. And they are what we think will happen is that they'll be on these drugs forever until we invent something better or cheaper. And that's going to be the management of asthma, is a biologic when it's appropriate, and then some air and MART on top of it. So yes, there will be a challenge, and it will be difficult because you're going to refer more patients to us, and we're going to have to deal with that. But that's our problem to deal with, and you should certainly not stop you referring these patients in. We do want to see them. I've got amazing colleagues like Arlene and Corrine, specialist nurses, physios, pharmacists who do this work with us and want to take this work on, and so please keep referring. Don't be put off.
Thanks, Tom. That is about as emphatic as you can be, and I think certainly the data around steroids that you shared with the reports, even on just short courses of steroids, I think we probably don't think about that in primary care every time we prescribe a course of steroids. We don't realise that just one course can have that increased risk of sepsis amongst others. So that's really useful data, and I think again just highlights how something that is probably thought to be quite benign, and we probably issue quite a lot of courses for in some patients, is not as benign as we think. We have got one more question so far, which is there, from Aisha Siddiqui, is there a role for a plain ICS inhaler in patients who only take SABA occasionally and before exercise? So ICS rather than ICS and formoterol. There we go.
Excellent. So there is no role at all for a patient who only takes SABA occasionally before exercise. That's the key thing here. So as they say in the vernacular, I reject the premise of your question, because that person shouldn't exist. So if you have a patient who only takes SABA occasionally before exercise, you need to see them and stop that, because those are the people who do badly. They're a subgroup of people who do badly. There's no evidence for it whatsoever. So that patient should be moved on to air. Take away their blue inhaler, give them a Symbicort, in my region at least, and educate them on air. Clenil, Kelhale, pick an inhaled steroid by itself. The role for those drugs is really diminishing now, because for mild and moderate asthma, the first line treatment and the push is an ICS LABA. Then even if that fails and you need to get somebody onto because they can't tolerate those types of inhalers, you're still going to be talking about Relvar or talking about Proxor. They're ICS LABAs. So ICS by itself has the use case for that is so small, it's hard to even think of something. So that's a good question. I'm glad that question came up. Get the person off SABA.
And I guess for Arlene, I guess one of the subtexts, certainly just last week, I had a conversation with a patient who I was thinking, can you stop taking your blue inhaler and actually use more of your MART actually as instead of using the blue inhaler? And it can be quite a big concern for patients to feel like they haven't got the blue inhaler, and they view it as something that helps them in an exacerbation. But I think it is a culture change of realizing you can take more of the inhaler that you take for prevention as a reliever as well, and it's a big change.
Yeah, and I don't want to gloss over how difficult it can be, because some people are absolutely married to their blue inhaler. That's what they've been told for 20, 30, 40 years. As long as I've been alive, it's been brown inhaler, blue inhaler. And some people, it's very hard to shift that, because they were told in 1986, take your blue inhaler 4 times a day, and they still are doing that. And we have to accept that that's human nature. And some people will not shift that, but we have to have the conversation. And if you're stuck with it, that's all they'll do. Then document it clearly, and that's what we're doing. But it's time to sit with people and explain to them that it's okay. You carry your Symbicort inhaler with you. That's the one you have. You take it as and when you need. and when you're worse. And when you have an asthma attack in Tesco, that's the one you reach for, and you take some like to be agonist.
Fantastic.
Arlene has her hand up.
Yeah, Arlene.
I was just going to highlight, because it is quite confusing, the terminology, because formoterol is technically a long-acting beta agonist, but I suppose to highlight the reason that it's only the formoterol containing devices that are licensed for Air and Mart is because they actually have a very quick onset of action. So they are getting a quick-acting, long-acting beta agonist as opposed to their SABA. So they are getting that relief from that formoterol element. And it's not we're just giving them the long-term bronchodilators. They are getting that relief and inhaled corticosteroid at the same time.
For sure.
I'm going to use that very quote when I next speak to a patient who's reluctant to come off the blue inhaler and say, I know a very a specialist pharmacist who told me that. So thank you. Okay, I'm mindful we've gone slightly over. Lots of really interesting questions and fantastic talk. So I think just remains to thank Tom, Arlene and Corrine for a fantastic, thought-provoking, multidisciplinary session. And certainly I've taken a lot away from today. If you could please scan the QR code, click the links to review and provide feedback. Helps us to make sure we're delivering useful clinical sessions for colleagues. We have got a link there to the future webinars, past recordings, feedback forms, etc. And there's going to be another session on Wednesday, the 3rd of June, and that's going to be the same time, 5 till 6. That will be gynecology pathways, and the link to register is there. So I think that brings us to a close. Apologies slightly late. Thank you for colleagues for bearing with us, and thanks again, Tom, Arlene and Corrine.
Thanks so much. Thanks for having us.
Thank you.